We feel that for a long time, those living with severe mental illness have been told what to do, have been silenced, restricted, and excluded.
People with severe mental illness die between 15 and 20 years younger than the general population from entirely avoidable causes. Our services aren't particularly well equipped to deal with them because of fragmented care. What we're trying to achieve in Choice is access to all of the community assets that most of us take for granted. Access to public libraries, education facilities, leisure facilities. We take them for granted, but most of the time, for all kinds of reasons, mostly related to stigma, people with severe mental illness don't get access to them or feel uncomfortable about them. And the Choice Project really is trying to address that. This is the launch of the Choice event. Choice stands for Challenging Health Outcomes, Integrated Care Environments. And it's basically a social prescribing project for people with severe mental illness.
Always good to start with a definition. So here's a widely used definition of social exclusion, a complex and multidimensional process involving the lack or denial of resources, rights, goods and services, and the inability to participate in the normal relationships and activities that are available to the majority of people in society, whether in economic, cultural or political arenas. It affects both quality of life and the equity and cohesion of society as a whole. I think in a way that last point is particularly relevant, that if we have socially excluded groups in society, society is the poorer for that.
There's a lot of stuff in our society for people who experience what we would call everyday mental health problems, so they're the common mental health problems like anxiety and depression. However, there's a group of people who experience serious mental health issues, as we call them. So they would be more sort of, people would view them as more hardcore diagnoses. But this is just, I mean, in my immediate circle, I could tell you, 6 out of 10 people that experience this. And this is just, it's normal people having particular difficulties. One of the difficulties with these diagnoses is that people can become very socially withdrawn. They can become very isolated. So what we want to do in Choice is bring this population of people into the spaces and places that we all are, where they're entitled to be. And we're not talking about, special services, or we're not talking about things that are particularly for a group of people. We're talking about the spaces that we go into. So it could be going swimming, it could be going to the library, it could be going to an art gallery. And these are the challenges that this group of people face, would be coming into those sort of spaces. So we want to make it a wee bit easier for them to come in and just to be part of our community as they should be.
I'm probably one of the few people in this room who witnessed the closure of the old Victorian asylums in the UK. I remember working at Shenley Hospital, which was out in the stockbroker belt, as they called it, in Hertfordshire. I also worked for a time in Freer and Barnet Hospital, where in fact they're now selling flats for about £1 million. The problem with all of that wonderful real estate that was sold off in the process of community care, that it never really translated into assets in the community. It never translated into full mental health services for anyone. And I suppose the other problem with the idea of care in the community was that no one had a real good definition of what the community in fact was and how they were going to be supportive to people with severe mental illness. We've been in touch with a whole range of community organisations, from arts, leisure, sports. We've been in contact with all of the statutory and voluntary sector organisations that tackle mental health. And in having that community coalition, we're then able to construct a plan for tackling some of the health and social inequalities that I just mentioned. Well, basically, this is the second phase of the project. And the first phase was about building the community coalition with all of the people I just mentioned, all of the organisations, and getting a plan to help people. The second phase then is based on the funding from the Arts and Humanities Research Council. We were funded to the tune of about £2 million with contributions from various community partners. And in that way, this next part is really about providing those social assets to people with severe mental illness, and then hopefully it improves their quality of life and perhaps improves their health as well.
My background was in quantitative psychology, so I worked with data sets in government safe rooms, but I was really missing the contact with people, and it's a very, very nice thing to be close to a group of people that are, when you can see the difference that your work is making. So I kind of gradually moved out of that and into community research, and probably where I've come to now in my career is I would not be involved in a project that was to do with mental health that did not include people with lived experience, and that includes in the design of it, as well as everything that happens in it and the delivery of it. So one of the most joyful things that we do is we work along with, you've interviewed some of the guys who are in our research group, and they come along to the university and they have decided the issue that they want to tackle with their research group, and they are working as researchers and developing the project, and amazing things are happening for the group and for us being involved with the group as well. It's really, really, it's just the nicest part of our week. So they're going to go out and they're going to conduct this bit of research, and they actually have the next bit of research planned as well. So for me, it would feel like it wasn't authentic if you were doing a mental health project and you did not have people. I mean, we have community partners, we have loads of different people involved, but if you don't have people who are actually experiencing the mental health issues that you're talking about, what are you even doing?
Our work will help others who have had similar experience to us. We have been included into a space that we didn't think we could have ever been in before.
I'm Gerard Martin. Previously, I did the last Vote of Voice about 2 years ago, so this was able to let me have the chance to do the research project. So then I was just curious about the research and what it was we were going to do and how we're going to do it and things like that. So a group of us just got together and come up with questions, and we've been able to get those questions turned from open to closed questions, and we've got to know each other and got to know each other's story. It was hard going. It is hard going. Research project's not an easy thing to do, because it does open up big cans of worms for people that have kept things inside for so long.
We're hoping to develop future research projects led by those with lived experiences. From our work, we want to see lived experience research embedded in universities, and in fact in all educational providers and governmental departments when making decisions. I have been living with mental health issues since I was about 14, 15. Then whenever this project came up about research and education and finding out why people with mental health have barriers put in their way to getting education, it felt very important to myself, because I have been through a lot of those barriers. When I was 16, I left school because of my mental health. I had to leave my home, started living on my own, and I had to get a job. So I couldn't go into education. A few years later, when I tried to with my mental health, there was nothing there for me. There was no support. There was no offering to allow me to take extra time, extra funding for some of extra facilities that I might have needed. So basically, I tried several times to do some A-levels, didn't work out because there was no extra time given to me. I always became ill and was late on assignments and stuff, so that didn't do very much good for my confidence. So for 30 years or so, I just gave up on it. Then this research came up, and I was actually quite annoyed when it first came up, and quite shocked that things haven't actually changed very much in 30 years. There's still an awful lot of barriers stopping people with mental health illnesses getting back into any form of education. There's people with mental health illnesses leaving school without GCSEs. They can't get into universities, colleges because of their mental health. And to me, that's just quite disgusting. So it is, I mean, we are
So what do we do?
we are the same as everybody else. We have the brains, and from speaking to people with mental health in some of the day centres that I've gone to and with volunteering through Inspire, I have noticed a lot of people, even in our centre in Aspen, there's people in there with degrees. We have a doctor of psychology in there, but yet society will still class us as being stupid. It is, you've got mental health issues, you're thick. That's one of the stigmas that's still out there. We aren't given the opportunities, we aren't given the chance. I would also love to see our research being the catalyst that starts a new way of thinking about people with severe mental illness. Small changes within the educational system can encourage and enable those with mental illness stay in education or even pursue further education. Education can benefit the person with mental illness in so many ways, ultimately improving their standard of life, lowering social exclusion and loneliness, learning new skills that will benefit society, possibly a gateway to returning back to work. Those with mental illness must not be treated like raggy dolls. Put us in a box and forget about us, and the world is going to be deprived of so many great minds.
My name's Carla. I've had mental health issues most of my adult life. I started going to Inspire about 2 years ago, and for the last 6-7 months I've started becoming more involved, and I was asked did I want to do this research, and sort of went curiosity, to see what it's about. No, if I don't like it, I don't have to come back. But I was hooked. Immediately I was hooked. I was like, this is something that could make a difference.
Our research topic is very thought-provoking, and we are learning from each other consistently. We are all more vocal and confident, and being a part of the research group has raised self-esteem. We all know how to have a bit of crack and usually have a laugh together too. I think the thing I have enjoyed most is thinking about the future and the progress that we are making, or that we will make for generations to come. Through my experiences and my work as a researcher and the research work of the group, I am giving something back.
I've got two children, not young anymore, they're teenagers now, but one of them has her own difficulties, and something like this could help her or her children. This isn't about my generation as much, it's about the next generation and the generations that come after that. And making education accessible for all it's essential. It's not just something that, maybe it would be good. It's essential. It doesn't matter whether they want to learn in a classroom or whether they want to learn a trade or hairdressing or anything like that there. It does not matter what education it is, as long as it's available.
What have you not enjoyed about the process? The length of time research takes. None of us thought we would still be here doing this, but here we are. Creating a survey and trying to word questions correctly and consider how you want people to answer was time consuming and at times very frustrating. It's also very difficult to decide what you must focus on, especially when you're leaving out questions that you really want the answers to but aren't relevant to the particular piece of research you're doing. Sadly, through our discussions, we have found out just how bad some of the educational facilities have been for people with severe mental health and how some haven't progressed.
The place where we have seen sort of results coming is through the research group, but we have been out meeting assets in the community, and this is all over Northern Ireland. So if anybody wants to become an asset, then please get in touch with us at the Choice Project. So for me, it's been learning what's out there in my community. And for example, I went and learned about the park run, and the park run is something that almost has the ethos of choice built into it. They have two main rules. You can't run into traffic, and you have to be near a cafe, because the kind of social part of it is really important. So anything that whenever we're bringing people on board, they have to make that commitment to sort of might be like, it would be nice if we can get some free spaces, but it's more things like, we know what the building's like before we go along. You know, somebody might come along with the person the first time they come, but if somebody is there to show them around so they can kind of, you know, get their bearings and stuff, then that would be brilliant as well.
Projects that have been done in the past have been kind of top down, but you really need to understand what the lived experience is and understand what their needs and preferences are and how they can engage us. So that we've been engaged with people with lived experience right from the beginning. They've been part of our committees, they've been part of our workshops and groups, and they've given us the ideas about what we need to do to go forward. And they will continue to do that in terms of providing an understanding of the project, how it works best, how it works best for different people. All of those kinds of things are essential.
Social interaction, intellectual stimulation, and a sense of purpose are just as important for improving health outcomes and life expectancy as a role played by things such as healthy diet, exercise, and medical care. Having a sense of purpose, have an understanding of your contribution, the part that you play, and the difference that you can make is hugely important to each and every one of us.
We had a person who talked to us, she wanted to go on holiday. She had not been on holiday for 20 years, and we just suggested to her she goes to Newcastle for a day. We chatted with her, and we had discussion about, do this, do that. We'd suggest you do this, we'd suggest you get insurance, anything, you know, just a wee half-hour chat. Following week, she comes back, Gavin, I'm going to Dubai for a fortnight. You know, so just from that one wee chat with her, she's gotten out, she's went halfway across the world, and that's all people need is a little chat. So it is bit of support, bit of moral support, and who knows what could happen.
There have been various things around the arts, and people have really engaged with that. We had a Photo Voice project, which really, Photo Voice is about trying to obtain the voices of people who you very don't often hear about, and sometimes they're reticent about coming forward. But it's a way of working with them to understand their experiences. And so we developed a wonderful exhibition which we had in number 2 Royal Avenue last year.
Arts Care, we're a charity. We've been in existence about 34 years now, offering arts and health interventions across the health and social care spectrum in Northern Ireland. So we're mainly commissioned by the government, by the Department of Health, and we provide around 25 artists across Northern Ireland, sort of little groups in each of the 5 trusts, and the artists can be musicians, dancers, and visual artists. Probably most of them are visual artists, a whole range of visual art, and they would go into health and social care settings like residential homes, mental health units, hospital wards, children's wards, and offer you know, arts and health interventions basically. So creative health, where the aim is to, you know, help the person rehabilitate after an operation through their illness, to improve their emotional health and well-being. Our mission statement is to improve personal health and well-being through the arts. So if I think about the patients or service users that we would engage with, probably the biggest area is undoubtedly mental health. You know, we would be around all the mental health facilities in Northern Ireland through the CAMS, you know, the child and adolescent mental health services, adult services, dementia services. It probably makes up the bulk of our work and the areas where our artists would go into. So obviously when Ulster University contacted us about this project a few years ago, we were absolutely delighted. You know, that it's about, you know, giving opportunities and arts and sport and activities for people with severe mental illness, so it's right up our street. And I suppose it's also a bit of a challenge, because I know this is aiming at people who maybe aren't already availing of our services or other services of the other partner mental health organisations. So it is a challenge, you know, to get out there. But there is such, you know, I think Jerry's Professor Leavey's research is showing, you know, how much discrimination there is in offering those social assets to people with severe mental illness. So we're delighted to be a part of the consortium. We're actually officially on as partners along with the other, you know, the key mental health charities. It's a great opportunity for us to, you know, just to, I suppose, raise our profile, but obviously get to those people who we know our artists can help, you know, and we have a lot of programs with, you know, things funded by the trusts, by the Department of Health, Public Health Agency, aimed at improving mental health. So it's just such a good fit, this project.
We often think about this the other way round, though, when we're thinking about how to address social exclusion. What is social inclusion? Again, writers on this topic will cover the fact that it's multidimensional. Often they'll talk about these dimensions of productivity, social integration, consumption, access to resources, and citizenship. And there are examples here in this slide of what we mean by those things. It's also important to think of this concept, though, as something which is very much dynamic. We tend not to be at the same point of social inclusion or exclusion all the way through our lives. Certainly it's true that as we get older, we tend to become more socially excluded, for example. And it's very much a multi-layered concept. We can think about social inclusion in relation to ourselves as individuals, but also in terms of ourselves as members of a smaller group, like a family or another identity group, and also the social inclusion of our space in society. Whole countries, for example, can be socially excluded.
We have to date is inadequate to addressing the complex needs of people with severe mental illness. This project, as I say, runs for almost 3 years. By that stage, by the end of it, we should have a vast amount of information to be able to run the whole thing properly and then do a randomized controlled trial, which again are quite difficult and expensive things to do. But this is about the implementation and the impact that it has on people with lived experience of mental illness and what their needs and preferences are. We'll also have a long-term impact in that we will have developed a platform around community assets that all of those community partner organisations have contributed to.
This changes something for one person, then it's been worth doing, but we would like it to change things for a lot of people, and we just want people to feel that they're part of their communities and that they belong in them, because they do. The other thing that we're developing, this is all sort of centred on what we call the assets platform. So it's kind of social prescribing, but with a twist. In particular, it's bespoke for this particular group of people. So we would like that system to be handed over to the community. So whenever research projects come and go, but we want something that can be left whenever we're done, and people can still benefit from it. So we would like the method that we're using in choice to be something that carries forward.
So I think that the difference here is we're going to really be reaching out with all the resources we have and the expertise that we have in the mental health charities that are on as partnerships, and really targeting and getting the social assets ready for these people to avail of it. I think I'm excited about that. You know, those ourselves and the mental health charities do brilliant work with people with mental health problems, but there's always a cohort or a group who just don't avail of that, or aren't aware of it, or don't know how to avail of it. And this is we're hoping to bridge that gap, you know, and both arts and sporting opportunities and social opportunities, and all the benefits that brings to anybody, but would bring to people with severe mental illness.
For me, it's about giving something back to the community. I've taken a lot from charities by being involved as a member of Inspire, and getting an awful lot of support from them. So this is my time to give back to them and give back to the community, give back to people who have supported and helped me.
If we can design interventions and programs and systems that are designed with people that use those systems, for me, that's the way forward. We need a model of more collective care where people are involved in designing the systems that they're going to use, and we will just keep on working and chipping away at it, and we will make a difference.